Hi there, I'm Wendy McCallum, burnout and alcohol coach and wellness expert, and you're listening to Bite Size Balance, where everyday extraordinary women share their stories, expertise, and wisdom, all in the name of lifting each other up and creating a better life by design. Whether it's wellness, career, relationships, food, alcohol, mindfulness, hormones, or parenting, we talk about all things women's balance. If your life looks great on paper, but it still feels like something's missing, you're in the right place. Welcome to Bite Size Balance.
Well, hello there. Welcome back to Bite Size Balance. We have a fantastic episode for you today, and I say we because I am back with my sometimes co-host, Dr. Sarah Bailey, and we are finally interviewing someone who we have been waiting patiently to interview, who is Erika Burger, pelvic floor physiotherapist. So Erika is a bit of a wizard when it comes to women's pelvic floor health. And we have wanted to talk to her for ages because we've been touching on the role that pelvic floor physiotherapy has played for both of us in relation to very different wellness conditions. And we think that it's an area that women know very, very little about. Certainly, I didn't know anything about it until I met Sarah and would never have gone to see a pelvic floor physiotherapist myself if she had not recommended that. So we had a million questions, and this conversation is so interesting. We really implore you not to skip this one as a woman in midlife. Even if you're not having any obvious pelvic floor issues, this podcast is going to be really, really enlightening for you. So we talk about a lot of women's issues, but we also discuss some male issues and some children's issues in relation to pelvic floor wellness that a pelvic floor physiotherapist can support. So I think you're just going to find it so interesting. I learned so much, and I know Sarah did as well in this conversation. So let me tell you a little bit about Erika Burger. Erika has been a physiotherapist since 1995 and has worked in many different countries within many different specializations. She found her niche of pelvic physiotherapy after having a particularly pesky pelvis during her first pregnancy in 2006. Since that time, she's devoted herself to understanding the biomechanics of the pelvic region and how physiotherapy approaches can bring relief for bladder, bowel, and sexual function disorders and pelvic, hip, and low back pain syndromes. She treats people of all genders. Her clinic is an inclusive, supportive, and trauma-informed space, which focuses exclusively in the treatment of pelvic conditions. So we're going to talk about all of the pelvic conditions that a pelvic floor physiotherapist can support, and also what to expect if you do go to see a pelvic floor physiotherapist, what a visit is like, because it was certainly not at all what I expected it to be. And I think you're just going to learn so much, as I said. So I hope you enjoy this episode. Without further ado, here is Sarah Bailey and my conversation with Erika Burger. Hi, everyone. Welcome back to Bite Size Balance. I am here with my regular co-host and buddy, Dr. Sarah Bailey. Hi, Sarah.
Hi.
How are you today?
I'm great. How are you?
Good. Sarah's in her new dig. She moved into a new office over Christmas, and it looks really nice.
Yeah. Lots of light.
Yeah. And we have a really special guest. We have been talking you up, Erika, for a long time. We keep saying, and we're going to have a pelvic floor therapist, and we're going to have a pelvic floor therapist. Anyway, we finally have a pelvic floor therapist. We have, we have Erika Burger here with us today. Hi, Erika. Welcome.
Hey guys. Thank you.
We are really excited to have you here because Sarah and I are both big fans of pelvic floor physiotherapy, if that's possible. And
super fan. I'm a super fan.
Yeah. Something that I knew very, very little about until I met Sarah. And we have both had some really great results from pelvic floor physiotherapy, which we're going to talk about a little bit. And we have so many questions for you that relate to the role of pelvic floor physiotherapy for women, especially women in midlife, because that's sort of, for Sarah and I, sort of our main demographic that we work with. So maybe we can start, Erika. I'm going to let you tell us what a pelvic floor physiotherapist does and maybe how you got to where you got to with it.
Sure. Well, I think that the the history of physio. So in my training as a physiotherapist in the early 90s at McGill University was really, head, neck, shoulders, arms, hands, and then hips, knees, ankles, feet. And there was really very little about any kind of abdominal or pelvic dysfunction. And I happily went through my career practicing that way. And when I was pregnant in 2005 and 2006, I started to develop terrible pelvic pain, which was not totally unknown to me. I'd had, a history of endometriosis and a history of, painful periods. And I had fractured my tailbone playing ice hockey, but this was different. It was like serious pelvic pain that kept me from moving and walking and sitting and, sort of really, really limited the end of my pregnancy. And I knew lots of people around town. I was a physio that, I knew lots of practitioners. I went everywhere saying like, there's pain deep in my vagina. And everyone would just look at me and they'd try to treat my back and they'd try to treat my hip. And basically, the prevailing message I got was this just sometimes happens in pregnancy. It'll feel terrible the whole time you breastfeed. And maybe a year after you stop breastfeeding, it will feel better because it's hormonal. And I just couldn't accept that if I was saying the pain was deep in my vagina, why was nobody checking my pelvis? And also just that we were this is what we were doing to women, just telling them to suck up this terrible pain for 2.5 years or make a decision not to breastfeed or any number of limitations. And I just was like, seriously, that's what we do? I had never encountered this. So it was eye-opening to me. So after having my baby, I was like, someone must know something about this. So I started searching and I found that there was some things happening in the UK for sure, some things happening in Australia. I couldn't really find much of anything happening in Canada except for a couple of women in Montreal who were, really spearheading pelvic physiotherapy. So I, pleaded with them to train me and I started taking courses on everything I could. I did a manual osteopathic practice at the same time and just try to really figure out what was required to understand the biomechanics of the pelvis. What were treatment options, what kind of different conditions, could be treated. And so that was sort of how I started. Of course, that seems hard to imagine right now because there's pelvic physiotherapy essentially now across Canada in, smaller towns and cities, there's clinics advertising. So I know it seems like, oh, well, pelvic physiotherapy, but 15 years ago, this wasn't a thing. And so that's sort of how I came to it, was from having this really terrible pelvis that made me realize it made no sense to treat the body from head to waist and then hips down and miss this whole middle part, which why would we? There's muscles, there's bones, there's ligaments, there's tendons, there's everything a physiotherapist should be interested in is there. Why were we just ignoring it all?
Right. That's really interesting. So is there pelvic floor physiotherapy for men as well?
Oh, yeah, absolutely.
Yeah. So it's not just a female field. Yeah.
Trans folk, everybody has a pelvis. So pelvic is for everyone. It's for children, teenagers, women, men, women who have not had babies, women who have had babies, young women, postmenopausal women. Yeah, of course. Men have pelvises, 100%.
Yeah. It's so interesting that it's an area that was just completely ignored for so long. Yeah. Well, so we thought we'd start with Sarah, because Sarah and I have both had experience with pelvic floor physiotherapy. And we've kind of just touched on it in the podcast and other episodes, but haven't really talked in any detail as to what it was that we were getting support around. we thought we'd just quickly tell kind of our stories and experience with it. Sarah, do you want to start?
Yeah, sure. So I used to refer to Erika regularly, mostly for women postmenopausally, menopause, women with pain with intercourse, and women with complaints associated with pregnancy. That sort of was the limitations of what I thought pelvic floor physio treated. And then I suffered from sciatica the third time round for a number of months, and had, like you, Erika, saw everybody in town, because I know everybody in town, or feel like I do. Saw everybody for a number of months, was on a lot of medication. My life was very limited. And then another naturopath friend of ours actually was reporting to Erika that I wasn't doing so well. And Erika said, "What? Why isn't she in here? She's got sciatica. She should be in here." So I got an appointment with Erika, and she assessed my pelvic floor, which I believe at the time was very tight everywhere. I think probably Erika remembers. There's lots of tension, and basically she relieved my sciatica, and I, knock on wood, have not had it since. And I used to get it regularly. She also was able to help out with my back pain, which I'd had for 20 years. And again, knock on wood, I haven't had it since. And so I am a regular customer at Erika's clinic. I have tune-ups every 6 to 8 weeks, just to keep everything in line and balanced. And what I learned from that was that there are so many more conditions or symptoms that can be treated by pelvic floor physio. I've had patients with severe rectal pain that they're taking medication for, and it made sense then that Erika could treat them, because she's the one who, she and all of her colleagues are the ones who are able to access that area of the body in ways that other people can't. So that was my experience, and I think probably part of the reason why Erika had to build a bigger clinic is because I then sent every one of my patients to her, and now she's mentoring and supporting a whole bunch of other practitioners to provide excellent service. So that's my story, and I am forever grateful to the queen of pelvic floor physio sitting right here with us.
Yeah, and I'm one of those people, I think, who got referred to Erika's clinic. So I'm seeing a different physiotherapist, but have had really a wonderful experience with it. Had no idea what pelvic floor physiotherapy was. It was Sarah who suggested to me that I might want to look into it. And the reason I was looking, I needed some support was because I was not having much luck in dealing with the vaginal pain that had developed as a result of going into full menopause, like almost overnight. It was a very harsh transition for me into menopause, and went from just kind of a life of regular cycles to no period. And the bottom, as I say, the bottom kind of fell out of my world. And I developed all kinds of symptoms, but one of them was vaginal pain. And so Sarah recommended that I go see a pelvic floor physiotherapist, and really did not know what to expect. We're going to talk maybe a little bit more about that, because I think it'd be great to just talk about what happens in a pelvic floor physiotherapy room. But it was such an eye-opening experience for me. And lo and behold, it seems, because the problem seems to have resolved itself, that the real issue was in relation to what was going on with the musculature and such. I'm clearly do not know exactly what I'm talking about here, but in my pelvic area. And that was actually tight in places, so tight that it was causing some pretty intense pain. And physiotherapy, just like it would help if you had, injured a muscle somewhere else, was incredibly helpful in relieving that pain. And knock on wood, as Sarah says, it's been really, really good since then. So that was my experience with it. So, totally different situations for Sarah and I, but, both of us have gotten really great relief from pelvic floor physiotherapy, which is, again, why we wanted to have you on here today, Erika. Because I think women just don't know that this even exists. I did not know this exists. I sort of had heard about it, but only in relation to, I'm going to say it wrong, but like abdominis recti or something. When you're after pregnancy and your muscles in your abdomen kind of pull apart, that's the only thing that I knew pelvic floor physiotherapy might be helpful for.
Yeah.
So maybe we can start with, maybe you can answer this question, like, why don't women know about this? Do you think? Why is this something that comes as a surprise to so many people?
Well, I mean, thankfully that is changing a wee little bit, right? Like initially when I started my practice, like I had to pound the pavement teaching women's groups or physician groups, or, you know, what kind of conditions could be helped by pelvic health physiotherapy. I think the fact that thankfully it's a bit better and there is more awareness, but there's still, of course, loads of people every day. Someone is here who says, oh my God, why didn't I know about this 7 years ago? Or, oh, my life would have been so different if I'd met you 5 years ago. I hear that every single day. And I think that just goes hand in hand with the fact that, you know, we don't talk about these things. Like we don't talk about our bowel movements, or, you know, who's going to call into work and say, I need to be off for 2 weeks because I have stabbing pain in my left testicle. No one's going to say that their clitoral pain or their anal pain or their vaginal pain, or they're going to say they have back pain, or they're going to just keep it clouded in mystery. But, you know, we don't talk about these body parts. Often we don't even have a word for them. People sometimes don't know their own anatomy. And the thing they're telling you is painful actually isn't the thing once you identify it on their body. And so very sadly, we still have, you know, our sexual and reproductive function and our elimination functions are still like a taboo topic. And so people suffer alone, not understanding what's going on in their body. The other thing is, you know, because this is a new area and the evidence and literature is just emerging, it also, you know, the physician, their first point of contact in the healthcare system also are taking an approach that's, you know, looking for infection as the first probable cause. So, you know, even further stigmatizing is they pitch up at a walk-in clinic or emergency, and, you know, the first thing that's done is a STI test, you know, and then other procedures which may in of themselves be traumatic or painful, when, you know, muscles seem a really likely cause. Like, why aren't we thinking muscles as a driver and perpetrator of pain? Instead, we tend to look to the organs or to the skeletal system, right? So people get sent for pelvic x-ray, they get sent for pelvic CT. There are lots of different urological tests that might be done on the bladder, on the prostate. But it's funny that, you know, muscles and fascia aren't considered as, you know, the potential source of the pain and dysfunction. It's not always pain. We're talking pain just because those were the scenarios that brought you here. But of course, we see loads of people for, you know, urinary leakage or urinary frequency or nocturia. They're up 7 times a night to pee. So it's not always pain that brings people here. But I think pelvic pain is probably the most veiled and secret kind of an isolating diagnosis that we experience here for sure.
What would you say are the like, is it possible without giving a 100 item list to tell the listeners, the range of which you treat? You just touched on some of them there,
Sure.
but just to like give an idea, because again, like I didn't think sciatica was something that I should be seeing you for.
Right.
So, what are some of the obvious and some of the not obvious things?
So on that topic, the sciatic nerve passes to get from your back down to your legs, passes through your pelvis, right? And can become entrapped in the pelvic floor. So, so I mentioned kids have pelvic health physio is important for kids. So we can see kids who bedwet. We can see kids who have urinary frequency. So they're peeing every 30 minutes. They have to keep leaving class, We could see kids with urinary leakage in the day. So they're wetting their pants often without even feeling any sensation. We could see kids who have involuntary loss of stool. That's called encoparesis. So little bits of poop are coming out and they have no control over that. It might, roll down their pant leg and be on the classroom floor and, so there are conditions for children, definitely, that we see. We also could see a whole other different kind of kid. We could see a neurodevelopmentally challenged kid with poor core strength who, is tipping over all the time, doesn't have good core strength, and that affects their gait pattern. And so we could be seeing kids for pelvic rehab in that way too. So those are different kinds of kids we might see. We could see teenagers with painful periods. We could see teenagers with pelvic pain, like as athletes. I see a number of teens who are high training in their sports field of dance, of track, of whatever, with urinary leakage during activities, hockey, soccer, who are overtraining their core and causing disruption to kind of the coordinated function of the core around governing bladder, bowel function. So we see those kind of teens. And then, moving into the debut of sexual activity as a teen, we could see females with pain with intercourse. We could see males who identify as gay who are having pain with anal intercourse. We could see trans folk who have had surgery, gender-affirming surgery, and lots of scar tissue or pain following those surgeries. Then moving into, sort of in 20s and 30s, we could see lots of folks with pain with sex, absolutely. We could see people with repeated UTIs, male or female. We could see women who are pregnant and see them in their pregnancy checks. And then we could see them in their postpartum checks. Sometimes we see people, we haven't seen them while they're pregnant, but they have a 3rd or 4th degree tear during delivery or have some kind of birth trauma and either pain or poor bladder bowel function after their delivery. So that's another big cohort of people we see. I'm just moving through the age span here. And certainly as we get into perimenopause, we see a lot of changes. So we see a lot of people who start to have painful intercourse, chronic and recurrent urinary tract infections, difficulty with bladder function, either they're leaking, they have urinary urgency or fecal urgency, they have a hard time controlling their back passage, so they're unable to control gas. We see people with chronic constipation, abdominal pain. And then there's the more orthopedic-y stuff, like what brought Sarah here, like chronic hip pain, chronic low back pain that's not resolving with typical rehabilitation inputs. So they've gone to physio, they've gone to chiro, they've gone to osteopathy, they're doing home exercise programs, and this pain will not go. Well, then we say, well, maybe, what's happening is there's some dysfunction within the pelvis, the basin of the pelvis itself. And maybe, some of these attachments, either internally or externally, are problematic, but they're in places nobody touches. So you've been going for massage forever, but nobody's getting down and in around the attachments to the pelvis. So, and I'm going to keep going through the age span now. And so we see that kind of orthopedic hip back, kind of, sciatica population, labral tears of the hip. We see lots of men at sort of midlife, 30s, 40s, 50s with sitting pain in their testicle, pain in their penis, pain in their perineum, feels like there's a golf ball in their anus. They have pain with ejaculation. They have a burning kind of pain that is not infectious in origin. So that's been all ruled out by urology. And they say, look, this is chronic pelvic pain syndrome. Go for pelvic physiotherapy. We see a lot of men with chronic non-bacterial prostatitis, which means they've been diagnosed with prostatitis, but when they actually swab and run culture on the prostate fluid, there's no infection. It's just they have deep internal pelvic pain. And so we work on the muscular and fascial attachments around the prostate and the bladder to release that tension. And, it helps that pain significantly. Another kind of similar, I just wanted to say that interstitial cystitis and chronic pelvic pain syndrome kind of, there's this interplay of painful bladder syndrome, chronic non-bacterial prostatitis, IC that go together. So there's a whole world of people out there who have burning pain around their bladder, or if they have a prostate that is very nebulous and hard to diagnose, but is super, super problematic in daily life. And so we do see a lot of those people as well. We see men who are preparing for a radical prostatectomy and teach them how to activate their pelvic floor in advance of the surgery. And then we see them post-op for bladder, for pelvic retraining. So lots of men post-prostatectomy have urinary incontinence and erectile dysfunction. So we treat that crowd. We treat men with erectile dysfunction, and they could be young, they could be old. There's a lot of pelvic floor retraining that helps erectile dysfunction. And then back to women, we certainly see lots of women in the peri and post-menopause period with various pain syndromes of vulvodynia, burning of the vulva when they sit, vestibulodynia, kind of a clamping down of the muscles of the vagina when anything penetrates. We see women with pudendal neuralgia, which is a tightening of the muscles around the pudendal nerve, making sitting and standing very, very painful and difficult. We see tailbone pain, often non-traumatic or after a slip and fall. So there's lots of acute and chronic conditions of the pelvic floor that I think are not widely known, because it's unlikely someone is going to tell you they have proctalgia fugax. Have you ever heard of anyone with proctalgia fugax? So that's an unbearably painful spasm of the external anal sphincter that often happens at times of stress or even in the middle of the night. It's like a Charlie horse, but in your butt muscles. So you can imagine, you're probably not leaving the boardroom in a big meeting telling everyone that you just had a giant muscle spasm in your behind, right? And so, but these are conditions that people have. There are muscles there. So muscles will do what muscles will do anywhere in the body. They'll do it in the pelvis as well. And it is a site of potential rehab. Just like you guys said, why would you not rehabilitate something that's causing these huge issues in your life. And a physiotherapist makes sense if the issue is being driven by muscles, fascia, ligaments. Yeah.
Yeah. I always tell people who've had any abdominal surgery, so C-sections, appendectomy, anything like that, that they should see a pelvic floor therapist as well. Because it seems logical to me that if there's any scar tissue, then it could be affecting anything else that's going on.
Yeah. That is so interesting to me. Sorry, I had no idea. This is like, Sarah probably knows all of this. I had no idea that so first of all, I did not, for whatever reason, I assumed that the clinic was mostly serving women. So I think that's fascinating and it makes total sense to me as you describe all of this. And I definitely had not thought about children or teenagers for that matter, really. So all of that was really, really interesting to me. And but it all makes perfect sense. And it's still boggling my mind that 15 years ago, there was no real organized support for this, for all of this stuff. So that's really fascinating. Sorry, Sarah, can I just ask a question and then you go? I just
Totally,
had a follow-on question, because as I was listening to Erika, what I was thinking was, because Sarah and I have talked a lot about vaginal atrophy / GSM on the podcast, and the various symptoms of that. And I've also done a lot of research on that on my own. And a lot of the things that you were talking about in relation to that you often see with perimenopausal and menopausal women in terms of symptoms or conditions that you're supporting or treating are also things that are often attributed to vaginal dryness. So I think that's really interesting, because I think that's what happened to me, is that I just assumed that I fell into the vaginal dryness category and that was the main problem for me. But what I learned, and I tried to do all the things to support that, but I think what I've learned is that it was probably more a muscular issue than it was that. So I think it's great that you did you agree with me? Am I kind of right on that, or am I way off?
No, I think just, it's again, what is the thing that the provider in front of you knows about, right? And so at least vaginal dryness, like, thank goodness, has risen to sort of popular attention and is marketed, and thank goodness for that. But of course, that's not the only thing that could be going on. Like, vaginal walls are muscular walls of tissue. And so, but it can go hand in hand. If you're having painful intercourse, you're likely to tense up, and now you're tense. And so, and so it's rarely that there's like one input, right? And that's what I always say to like most of my clients, especially my pain clients. It's like, okay, we got to work with the nervous system you have. We're not going to, people who hold tension in their body tend to be people, who feel a lot, who have a nervous system. And these are the wonderful helpers of our society. Like, we can't have everybody be a water off the duck's back kind of person, or nothing would ever get done, right? So we need the people who get the stuff done. But the impact of having a kind of highly regulated nervous system that's like tuned into your surroundings, that's like anticipating issues, like caring for things, getting stuff done, is that you've kind of got this ambient tension in your muscles so that you're like ready to do stuff, right? You're on the ready. And the problem with that can be that you can then fall into muscular guarding patterns where you're holding and guarding, and it makes tons of sense from an evolutionary point of view to guard and hold through the core, right? When we were down on all fours, our belly was like kind of away from our predators, right? It was down close to the ground. And when we got up onto two legs, we opened like the most vulnerable part of our body open for attack. And our heart and lungs are like all nice and safe inside our rib cage, but like our whole abdominal cavity is just like there, ready for. And if some creature came and got like our finger we might survive the attack, but if it gets us here, we're a total goner, right? So when our sympathetic nervous system is activated and our fight, flight, freeze is the predominant thing that's going on in our autonomic nervous system, it makes sense with that perceived threat to tighten up our abdominal wall and our pelvic floor as an act of self-protection. The problem with that is that can become how you go through your day, like all day, every day. And even at moments where you might let your guard down, your muscles, because of muscle memory, knows this. And so you're holding. And so trying to have people understand like the various inputs. Okay, yeah, you might need vaginal moisturizing. You might need internal vaginal moisturizing. You might need vulvar and clitoral moisturizing. And you might need a daily meditation practice. And you might actually need to stretch your QL and your hamstring, and you might need to. So often it's like there's this, and there's that, and we want to kind of tackle it, from these various angles. And that in particular is true for our chronic pelvic pain clients, whether they have endometriosis, whether they have pudendal neuralgia, whether they have chronic non-bacterial prostatitis, whatever it might be. You're often looking at it from these various angles, and some are the obvious things. Moisturize that vagina, but that's not all, because no matter how moisturized it is, if you've got a muscle spasm in one of your, superficial pelvic floor muscles, it's going to hurt when it needs to stretch, right? Which it needs to do to accommodate something in your vagina. So if that tight muscle is now demanded to stretch, you're going to have pain. So it doesn't matter how moisturized you are, it's still going to be painful. And I think that's sort of where people have tried many things before they land here.
Yeah. That's so fascinating. Hey, Sarah, the connection between stress and burnout and your abdomen, like that whole, that just was like so fascinating to me, Erika, the idea that my body would be trying to protect my abdomen and holding tension there. And I work pretty much exclusively with women who are incredibly stressed and burnt out, and Sarah sees them all in her practice too. So that's really, really interesting. And sorry, go ahead.
I was just going to overlay that population that you're talking about, who might be the ones listening, is also to say, and then add to it, maybe you've squeaked out an hour a week or an hour a day of some fitness, and you're focusing on core exercise. You're doing Pilates, you're doing a lot of core workout because you bought a Beachbody. I don't know if I should say that, but you're doing some kind of fitness routine that now has you like clenching and tightening those muscles even further. And or overlay it with, you've just had 3 vaginal deliveries in the last 2 years, or a C-section and a vaginal delivery and an appendectomy, or a tummy tuck, or, anything, like all those inputs into your abdominal wall then challenge it even further. So it's like stress and scar tissue and a pre-existing diastasis recti and and so it's like doom. And so we have to sort of take that whole picture. And I would say that perhaps is the thing that makes pelvic physiotherapy a different experience for people who even had lots of experience with the practice of physiotherapy. And so they've had lots of physio in the past, and then they come here and they say, wow, this isn't like my other physio. And I think it's that, like, by the nature of pelvic dysfunction, we have to be holistic. We have to take all these things into account. We have to move into territory that's new or different for us as physios. We have to think about diet. We have to think about stress. We have to think about some kind of motivational coaching, and we have to be trauma informed. We have to be, so these are I hope that what we have done in pelvic physio will find its way into other aspects of physiotherapy too, because it makes sense that we work with this broad holistic view. And I'm not sure that's always possible, within the confines of physiotherapy practice, but we certainly make it a priority here at my clinic. We have hour-long appointments. We're in a private room that's very comfortable. We do lots of training on trauma-informed care, on, diverse care for diverse populations. So, trans health, LGBTQ plus health. So we really try very hard to become the practitioner with the skills that our clients need. But it doesn't necessarily feel like usual physio, I guess is what I'm saying.
Can you, on that note, can you walk us through an appointment, like your first appointment with you or your second, where there's an actual physical exam?
Yeah. So first appointment, we try to always do a physical exam if we can, because it's the thing that people feel stressed about. And sometimes, it's good to just see how it goes. But yeah, so an initial appointment, you would get a screening questionnaire to tell us what's going on through a safe server. So we'd be able to read your health history before you come. And then you would be in our rooms at this clinic are soundproof. So you'd be in a soundproof room with your physio, and you would have an hour to talk more about those symptoms, what's brought you to physio. Depending on how much you've written, your physio will ask you lots of questions about your urinary function, your bowel function, your sexual function, your experience of pain, your gynecological history, your broader medical history, your activity level, what is it you do? And then they would do probably, at our clinic, they would do a postural scan, see is your pelvis aligned? Are you hiked up on one side? Is your pelvis torqued or rotated? How are your SI joints gliding, your sacrum? So they'd have a look at all of that. How are you breathing? Can you take a deep breath? Can your diaphragm descend into your abdominal cavity? Then they would likely do a check of your abdominal wall. Is there tension? Is there scar tissue? Is there pulling? Are there fascial restrictions throughout your abdominal wall and down over your hips and your pubis? They may check and back and check along your buttocks, looking for restriction. And you would have your pants and your underwear off. You would be on a nice, comfortable treatment bed with bed sheets and blankets and heating pad and pillow. And they would then put you into a kind of a gynae position with your knees up, and we have nice cushions that your legs rest on. And then we would do a surface external examination of your genital area, trans folks, men, women. And this might not happen for children. For children, often we work fully externally. So it would depend on the age and the condition being treated. So I just want to make a caveat there. But ultimately, if you went to a physio to have your knee assessed and they didn't even take off your jeans and they didn't put their hands on your knee, you would think like, what a crummy physio, right? So ultimately, the gold standard is if we can assess the pelvic floor and it's indicated, we want to. So what we would do is with you in this nice, comfortable position on your back with your knees bent and resting on cushions, we would do an internal exam, and that could be through the vagina, and that could be an anal palpation. And we want to assess all of the various muscles of the pelvic floor. We'd checking muscle strength. We'd be checking for tension, for fascial restrictions. We would check like visceral mobility if you're coming to us for pelvic organ prolapse, which I should have mentioned long ago is another big group that we would see in the peri and postmenopause age range for women, are women with pelvic organ prolapse. So we'd be checking the mobility of the organs and the position of the organs. And then sort of how is the pelvic floor coordinating with the deep abdominals in providing support and structure to the pelvis. And at the end of that assessment, we would have a good sense of where, like, what are the main things we're looking to do. And so follow-up appointments are also an hour, and we might spend some of the time working on muscles that are outside of the pelvis but attach into the pelvis. So abdominal wall, low back muscles, some muscles down the side of the body, glutes, adductors, hamstrings, quads. So we could be working on scar tissue, muscle tension, asymmetry, strengthening. And then we'd spend another big portion of the appointment doing internal work. So it could be, the way I work is I might assess like the right side of the pelvic floor first with one hand and then come out. We're wearing gloves, we're gowned, we have face shields, we're using clean technique. We're following all of Health Canada precautions, obviously, and all of the rules of our regulatory body around infection control procedures. We do lots of manual techniques with our hands. So, even internally, we're releasing tension, we're doing trigger point release, we're doing fascial mobilization, we're facilitating muscles, we're inhibiting muscles, we're doing all kinds of things with our fingers as we work internally. And then we can use other things. We could use vaginal dilators or rectal dilators if we're trying to stretch muscle. We could use biofeedback or electrical stimulation units so that we can use a probe inside your vagina or inside your anus and try to activate muscles, encourage muscles to tighten and work. We can use it to inhibit muscles to get them to relax. We can use biofeedback so you can see on the screen what your muscles are doing, and we can play little games on there. You have to make the bunny jump up the mountain and then get the bunny to come down as you learn to tighten and relax the muscles of your pelvic floor. So there's a lot of different techniques that we might use in an appointment. And during that time, we're also, might be providing some pain science education while we're doing our stuff. We're talking, and we always try to drop in little bits of understanding of how pain actually works. Pain is always produced by the brain. It's never produced by the tissues, and trying to get people to understand some of the foundations of the pain they're experiencing. We might be offering some counseling around, different sexual health issues, or just an understanding how the body works. How do your how's your cervical mucus change through the month, or any of these things we might be talking about while we're working that might bring even more to the session and give people more ideas of what they can do.
It's so exactly what I experience, which is just, it feels so completely, I know we're friends, and so we yak about our kids and things, but it also feels like a very whole body, whole person experience. And never once have I felt embarrassed or even nervous. The environment that you create around feeling safe is remarkable. So I commend you on that. And the new clinic feels even more like that because you've really put an effort into doing that. And so I just wanted to say that it's really for the women and men who are nervous about this. It's really it's a very welcoming and safe space. Yeah, created by the people.
Yeah, I would completely echo that. That's exactly how I felt. I did not know what to expect because Sarah did not advise me what to expect. So I was a little surprised because I don't know why in my mind it was not going to be an internal examination, but it makes absolutely perfect sense. But I felt so
I didn't
comfortable.
tell you that.
I don't think so.
Sorry, I usually do.
I mean, you might have, but I'm menopausal, so I may have forgotten or whatever. I don't know, but it doesn't matter because when I got there, it was just so comfortable. I was absolutely not stressed at all. There was no feeling of being exposed or anything. I felt very, very comfortable. And I found it, I've said this before, just to be so incredibly enlightening. The things that I learned that I did not know about my own body were just mind-blowing to me and incredibly helpful and empowering. So it was just a really good experience all around, which is really why we wanted to have you on, Erika. And you've done a really wonderful job of explaining all of the, just a huge, obviously spectrum of types of things that you can support all people around. So I think it's going to be, most people are going to listen to this podcast and it's all going to be new information for them, which is, it's wonderful because we aim to inform here. Sarah, do you have a question?
Yeah, I do. I want to cover one more thing because we've talked a lot about pain. I just want to talk about peeing. So I don't know, maybe you told me that you were the only person at a sleepover, women's weekend kind of thing. You were the only one who could be on the top bunk because you were the only one who was not getting up to pee in the night.
Yeah.
And so I just wanted you to cover peeing in the night and what women can, because many women in my practice think they up 2 to 3 times a night is normal. And then the advice that they're given, if they even bring it up, is often do Kegels. And my advice to women before I send them to you is do not do Kegels until you talk to a pelvic floor therapist. Please stop all Kegling because of that, enhancing the pathology really, sort of enhancing the muscular tension. But can you speak to what is normal in terms of nighttime peeing, please?
Sure. Okay. So I would say that my tolerance for nighttime peeing is 0 times a night if you're under the age of 65. If you're over the age of 65, I might let you get up once a night, maybe, depending on the situation. But really, you should void once before bed, not, 6 times trying to just squeeze every little last bit out. You should not have to restrict fluid at night. I wouldn't drink 4 cups of herbal tea at 10 p.m., but also the solution to nighttime peeing is not to restrict further and further and further. I mean, I'll see people here, they're drinking nothing after 5 p.m. like that. That's not good for you. So it should be that you can have fluid at night and you can sleep all night. And you can just have one void before bed, not, pee and then read a chapter and then pee and then read 2 pages and pee and read another half page and pee and then finally think, okay, maybe I have it all out. I'll try to go to sleep and then be getting up multiple times in the night. So that would be for nighttime that are, it should be that you are not up at night to pee. If you're under the age of 65. And then I would say for daytime voiding, it's somewhere in the range of 6 to 8, 6 to 9 times a day for daytime pees. And so every, 2 to 3 to 3.5 hours. And I certainly see people on both spectrums. I see some people that, given the nature of their job, they've held for 8 hours at a time their whole career. And now they're presenting with all kinds of urinary dysfunction later in life. And I've seen all the just in case peers of the world who, I'm leaving the house just in case I'm going to go pee. I'm, going to get on a phone call. I better just in case pee. I'm going to do a podcast. I better just in case pee. So there's all the just in case peers who pee every, 45 minutes or every 30 minutes. And the thing I always say is like the bladder is very amenable to training. The thing you train it to do is the thing it's going to do. So when your baby is young, if you get up with your baby multiple times a night and pee every time you're up, and then lo and behold, your baby's not waking as often during the night, but your bladder is waking you and you're still up to pee, even though now the baby's sleeping through the night. So the question to yourself is always like, am I just awake? And I think this is especially important for women in perimenopause and menopause, because you can be awake quite a lot in the night. And that doesn't mean that each time you're awake is a time that you should go pee, right? You ask yourself, do I really need to pee, or am I just awake? And if you're just awake, do not let yourself sit up and put your feet on the floor and walk to the bathroom. That's not, you're just awake, that's different. And so I think that's really important, because patterns set in. Remember, muscle memory, right? Patterns set in. The bladder is one big muscle, the detrusor muscle. And so if you train it to do a particular thing, it's going to want to keep doing that thing. And so menopause is over, you're not up so often in the night from a kind of hormonal hot flashy point of view, but you're up to pee now. So, really ask yourself, do I really have to pee, or am I just awake?
That is
that's a biggie.
Yeah. Sarah, you're the just here.
Yeah. I drink a lot.
Yeah.
I drink a lot of fluid.
Yeah.
But I'm still like, I'm definitely a just in case. Like I want to pee right now just talking about it, because anyway, we'll talk about that at my next appointment, Erika.
Yeah. No, thank you, Erika, for sharing that. And I'm presuming that if you are somebody who pees more than the recommended peeing guidelines that Erika just set out, that pelvic floor physiotherapy might be a good place for you to start. So I think, Sarah, unless you have any other questions, I think we covered the main topics that we wanted to cover. Is there anything we haven't talked about, Erika, that you'd like to talk about? You think we've missed?
Maybe where to find a pelvic physio?
Yeah. So that was the last question I was going to ask. Okay. So our listeners are all over the place. Yeah. So we have lots of listeners in Nova Scotia and many in the HRM, but also listeners across Canada, North America, and even in other countries. So your clinic, why don't you start with your clinic and the information on your clinic? And I will put the link to Erika's clinic's website in the podcast show notes so that you can grab it from there if you're local. But then I'd also love it if you'd let people know in other places how they go about finding a pelvic floor.
For sure. Yeah, absolutely. So my clinic is in Dartmouth, and we're a dedicated clinic to pelvic health concerns. So the clinic is called the Pelvic Health Clinic by Erika Burger Physiotherapy. We have physios, we have massage therapists, we have orthopedic physios and pediatric physios. So we have a variety of services here, but we also are happy to help people find physios closer to their communities. So our receptionist, is happy to help you with that. We have a list. And if you call from Cape Breton and you say, Erika, you were lovely on the podcast, but I'm not driving 5 hours to see you, do not worry. I will understand, and we will help you find a pelvic physio closer to home. But in addition, the Canadian Physiotherapy Association has a women's health division. And on the women's health division of the CPA website is a tool called Find a Physio with a map of Canada. And just enter your postal code or click on your area, and you will see where the pelvic health physiotherapists are around you. And obviously a Google search would also help you identify people that are pelvic physios. And then within that, you want to find out, is that pelvic physio trained to treat women, like to just treat incontinence, or are they trained to treat pain conditions? Are they trained to treat men or trans folk or children? And so obviously there are different gradients of training. And so you want to make sure you find someone who's able to do able to treat the condition you're presenting with. So people can call our clinic if they're not sure, and if they want help, we're happy to be the person that helps. They can check the CPA Women's Health Division, find a physio website to find someone in their area across Canada, and we have, sort of social media connections with each other too. So we have a global pelvic physio group on Facebook, and we have a Canada-wide group. And of course, we're always sort of asking on there. I found my friend in Atlanta, a wonderful physio, by asking, who works in Atlanta. So, I mean, people, we find each other that way as well.
Oh, that's wonderful. Thank you. Okay. So, thanks so much, Erika, for your time today. I know how busy you are. It is, your clinic is growing because you're so busy, which is great because it means more women and men and trans people are finding you, which is awesome. And just learning about this period, which I think is so important. So that's fantastic. And I know that it was a big ask for us to get an hour of your time. And we really appreciate it.
Yeah,
thank you so much.
Thanks so much for having me, you two. I hope one day we'll be in the same room.
Yes, that would be wonderful. Yeah. Thank you so much, Erika. Bye.
Okay. Bye.
Bye.
You've been listening to Bite Size Balance with your host, Wendy McCallum. As a burnout and balance coach, I help busy high achievers like you create a more balanced, joyful life. If you've been putting yourself last for way too long and are worried that you're burning out, grab your free burnout checklist at www.wendymccallum.com/checklist. That's www.wendymccallum.com/checklist.